I don't know if Giovanni's on the line as well. No, he's gone. He's Corona gone. So we have Don and Deborah here, and I open this up to conversation.
Hi, I just wanted to say that I really liked this idea of intrinsic capacity that he spoke about. It's like how we used to talk about vulnerability all the time, and we finally started to flip that and begin to look at resilience and how you could increase resilience. And to move from frailty to intrinsic capacity, and then what can we do to enhance intrinsic capacity seems to me just way more positive and encouraging. It's just a comment.
Sure. And I think back to the conversation that we had a little bit earlier about PrEP. Let's spin it. Let's make it a positive. Let's not make it frailty. Let's make it, intrinsic capacity and resilience, as you comment on.
Thank you for the presentations. I just wanted to make a comment about weight gain and culture. Again, coming from Africa, because I think there's a lot of discussion because of the advanced trial, which was in South Africa. We work in Botswana. We haven't seen that same amount of weight gain. But with activists, and I was just in a meeting with 22 different countries in Africa, HIV activists, and weight gain, 3 kilo weight gain, people are absolutely willing and happy to live with. They're not, shame-based about fat in many ways like you are in the West. And I think we need to be really careful about that. So I think if we're talking about increase in lipids or, that's a different story. And we're not necessarily seeing that right now with DTG. So I just think we should remember that, what is fat in the United States is considered fat, is considered beautiful in other places, and just be careful with fat shaming.
And I think you're well taken, and I think one of the comments on those trials is, yes, this has happened, but does it bother you? And is it a negative for you?
Yeah, and I think that's a very, very important point. And there are a couple of pieces to the weight gain issue. One, obviously, is vanity, or how we might feel about our bodies. But the other is about actually what the impact is on knees and back, and especially with the bone mineral density issues as we're aging. I mean, I think that the reality is the weight change for a lot of women actually has some pretty significant impact in terms of their ability to be active and kind of physically how they feel. That's less an issue for most younger women, but especially as we get into the window of aging, it's something we hear over and over and over again, that I can't be mobile anymore. My knees are terrible, my back is terrible, my hips, I'm on my second hip replacement, et cetera, et cetera. So I think that we have to think about the weight gain not only as just kind of culturally and how we feel and perceive our bodies, but also what the impacts are on our ability to function.
I mean, what we're saying is the cause of that.
Yeah.
What implications are the cause of that?
Yeah. Sure. But that's even true here in the U.S. amongst different race ethnic groups, right? That weight gain isn't a bad thing. So I understand what you're saying too. On the other hand, within the WISE, we had a discussion about this, that we have a National Community Advisory Board, or NCAB, so that we regularly interact with them to provide insight related to what we measure. What are the important things? What do you want to know about? And they are not happy with the weight gain. They were asking for bariatric surgery at the last time we were talking about it. So I agree with you, but there are some don't want.
Annette, did you have a comment?
Yeah, I have a question to Dawn. So you said when we talk about aging in women living with HIV, we can't ignore menopause, the transition through menopause. But you criticized, I heard you, we physicians tend to say, well, it's all, it's aging, it's all due to menopause. And I was thinking, when patients of my age are sitting next to me and they talk about their symptoms, I think, I know exactly what you're talking about. So it might really be menopause. But how do you want us to communicate or to talk about menopause or the symptoms? So just give me an example. How can I change what I obviously do wrong?
Well, I think it's highly likely that you and many of the people in this room are far more sensitive in those conversations than, unfortunately, the vast majority of clinicians that most women see. And even in my own personal experience, it isn't that they're offensive with the suggestion that it is menopause. This is a statement of fact. You're perimenopausal. No one's going to change that. But the conversation about how we address your symptoms and your functioning and how you feel and everything else is a really important one. And I think for many women that I talk to, it's a write-off statement. Well, you're menopausal, you just have to expect that. And that's the end of the conversation. And it's not an ability to relate or to even say, well, what are the things about this that are most difficult for you, and how can we address them? Or who can I send you to? The clinics and the settings where you actually have a multidisciplinary team and there's the ability to see somebody who can actually talk about some of this in a knowledgeable way is incredible. But it's not true for every place, and certainly for every woman. So I think what I'm encouraging is actually the recognition, this is awful, I know, I'm got my own set of things. Which parts are changing how you function and your ability to take your meds or do your job or support your family or whatever it is? Because I think that what happens is especially, and this is not fair to say that all men, but for a lot of male providers, there's kind of it's menopause. And, I think what I hear from a lot of women is a great frustration that it's just like grin and bear it, sister, everybody gets, this happens to everyone.
So a lot of the people that we look after in the UK are African-born women, and the stigma is huge. And for a lot of them, the only place they discuss any of this is in clinic. And what worries me slightly in certain settings is that, particularly based on just sort of viral load results, is that people are being seen less and less frequently and have less of an opportunity to actually discuss all those other things actually that I spend a lot of time talking to the women about. You perhaps may remember to get onto their blood results, but for many women I think that then doesn't happen. And I've heard people say that they feel penalized by actually having an undetectable viral load because then they actually get seen less frequently. Yeah. Do you have any comment on that?
I mean, those of you who know me know that I am a huge advocate for participation in clinical trials and in research in general. First of all, I love data. And second of all, to your point, there are a lot of women who say, I go once or twice a year, I see whoever's on duty because there's a lot of people on rotation. I have no relationship. If I can't make it, I just don't go. And the connection to both the site and even their own care is just kind of sidelined. And for some women, not all women, but for many of the women that I have interacted with over the years, the opportunity to participate in a trial offers the ability to be kind of valued and appreciated and recognized, to have more regular care and somebody who's checking in on them in a more consistent level. And sites that do research well do things like have somebody check in and just ask 3 questions that have nothing to do with HIV. So now you're a real person and not just a patient or a subject. So I think that that's one of the ways that some women are finding an opportunity to kind of connect and feel like they're giving back and participate. So I think that we unfortunately don't talk to a lot of women about participation in clinical trials, or we miss the opportunity this time and it's another 6 months, 9 months, or a year before we get that opportunity. And I would encourage, as you talk to your peers and people think about how to reach out, that's a really an important opportunity to kind of reach out to women and say, is this something you'd be interested in doing? Because you're a partner in this process. Like we can't do this stuff without you. And again, it's a framing issue, but it's an opportunity.
Well said.
I just wanted to add, too, that as part of the Max Wise Combined Cohort Study, we will be recruiting new participants.
So here's your chance, sign up.
Just as that's true for the RCT space, for the clinical trial space, it's also true for the women who participate in our prospective longitudinal cohort studies. So, and they comment on this all the time because it's been an every 6-month visit in the past, and it won't be quite that frequent as we go forward. It'll be annual, theoretically annually, depending on how long it takes us to get everything measured, but that's the theoretical goal. Yeah. So we'll be recruiting at those sites I showed you on the map, and then there is another cohort that's been funded in the South. The PI is at Atlanta. I think she's either Atlanta or maybe Miami, I can't remember. But, so there is going to be some active recruitment there as well. So I would just encourage you to look for those types of opportunities too.
And we've actually started an aging cohort as well, and again, over 65 years of age, and exactly what you're saying. This is their opportunity to talk, and
Yeah.
we envision clinical visits for the trial to be an hour. They're 2 and 3 hours because
Yeah.
somebody's listening to
Yeah.
them.
Right.
Perhaps the last comment, yeah.
Thank you all very much. So I work in Brighton in the UK, and I'm lucky in that we have a women's clinic that we started, and it's multidisciplinary. So every woman sees a social worker to talk about domestic violence and are they safe at home, me for medical, and then I see a nurse as well, but we also have a menopause expert. So every woman is evaluated for menopause symptoms. One of the many things that we evaluate. But I think, as Anna Meek said, as we see patients less and less in clinic, the opportunity to have that discussion, particularly if somebody isn't skilled in having that discussion or then knows what to do with the information they're being given. Every woman in the clinic is asked to come to this clinic at least once, and it's a long clinic visit, even for women who are really, really stable with a viral load undetectable for years. They can be with us for 2 hours because it's the first time they've had that opportunity to talk. And I think it's hugely important that in all our amazing virtual follow-up and improvements in HIV care, that we don't lose sight of the fact that actually personal contact is vital, and peer mentoring remains hugely important, and women's groups are hugely important, and we're very lucky to have that in Brighton as well with the Sussex Beacon.
Great. Thank you for your comment. Okay, we're going to need to move on, so I'd like to thank our speakers from this session very much. Thank you.